So today we talk about STI, and we said that STI infections that are passed from one person to another through sexual intercourse. And we are meant to know that infection is when a bacteria or virus or parasite enters and grows in the body. And we also know that another name for STI, sexually transmitted infections, are is called sexual transmission diseases. Then we are meant to know that the infection affect both men and women of all background and economic value. And more than 1 million STI acquire every day worldwide. We are meant to know that if STI is not treated, it can cause ulcer, it can cause cancer, it can cause PID, it can cause infertility, it can cause pregnancy problems, it can cause widespread infection to other parts of the body. Untreated STI can cause organ damage and even death. And we must know that drug resistance is a major threat to reducing the burden of STI worldwide, because most drugs that are indicated that are used in the treatment of STI are antibiotics. And we all know that antibiotics is one of the major class of drugs that has been abused by both young and old. So this contributes to drug resistance in the treatment of STI. Then we talk about the risk factors, including alcohol, drug abuse, multiple sexual partners, incorrect use of condoms, sharing needles and sharing sharp objects. All these are high risk behaviors for STI. So let's see high risk population. Women are more close to STI than men. Then STI is common among adolescents and young adults between the age of 19 to 24, and is also common among homosexuals, gays, lesbians, and what have you. Then let's talk about type of sexually transmitted infections. We have bacterial infections. Examples include chlamydia, gonorrhea, chancroid, syphilis, and etc. Then talking about viral infections, that is infection caused by virus. We have HIV, we have herpes, and hepatitis B virus. These are just examples of viral infections. Then we have parasitic infection like Trichomonas vaginalis. Then let's talk about chlamydia infection. What is chlamydia infection? Chlamydia infection is a sexually transmitted infection caused by bacteria called Chlamydia trachomatis. It is the most common sexually transmitted disease among young people. Two-thirds of new chlamydia infection occurs among youth age between the age of 15 to 24, and one in 12 sexually active young women aged 14 to 24 has chlamydia. So that's according to a research. So the incubation period of chlamydia is 1 to 3 weeks. Then that means like chlamydia infection symptoms occur between 7 to 21 days. Then let's talk about the mode of transmission of chlamydia. The mode of transmission is through oral sex, through vaginal sex, through anal sex. Then it can also be transmitted through childbirth and through direct contact and sharing of sex toys with affected persons. Chlamydia infection is silent disease because 3/4 of women and half of men have no symptoms. And if they have symptoms are noticeable after 2 weeks of infection. Then let's talk about the general signs and symptoms of chlamydia. In men, there will be pain when urinating, called dysuria. Then there will be a white, cloudy, or watery discharge from the tip of the penis. There can be burning sensation around the urethra area. There can be pain and swelling in the testicles. Then there can also be conjunctivitis as reddening of the eyes. That's for men. For women, So when the infection affect the fallopian tube, women experience low back pain and abdominal pain. Bleeding between period also occur in women. Then pain during sex or after sex. There can be discharge of bleeding from anus. Then in pregnant women, it can also cause premature delivery. Baby can get infected in their eyes or respiratory tract, using causing infant conjunctivitis. Then let's talk about the diagnosis. How can we diagnose chlamydia? We can diagnose chlamydia through microscopic culture and sensitivity test called MCS. We can also diagnose it through direct immunofluorescence assay. We can also diagnose it through enzyme leak assay and linkage chain reaction. So these are how we can diagnose chlamydia infections. Then let's talk about treatment. So according to WHO, the standard recommended treatment for chlamydia include doxycycline 100 milligrams 12 hourly for 7 days. So for patients that have allergy to doxycycline, you can actually use azithromycin 1 gram orally in a single dose. Then for pregnant women, you can use amoxicillin 500 milligram 8 hourly for 7 days. And for pregnant women that have allergy with penicillin drugs, then they can use type erythromycin 500 milligram 6 hourly for 7 days. So these are the laid down treatments according to the WHO for chlamydia. Then let's talk about the pharmaceutical care for chlamydia. Then I wrote that doxycycline should be avoided in pregnant women due to dental discoloration. So it has been observed based on research that pregnant women that use doxycycline also doxycycline affects neonates or infants when their mother uses doxycycline during pregnancy. Then doxycycline should not be co-administered with anti-acid, iron or dairy products due to the chelating effect. Then patients taking doxycycline should not be exposed to sunlight due to photosensitivity effect. So we are done with chlamydia. Let's run through gonorrhea. Gonorrhea infection can be defined is a sexually transmitted infection caused by a bacteria called Neisseria gonorrhea, which is a gram-negative aerobic organism. In 2020, WHO reported that more than 80 million cases of gonorrhea infections, making it the second most prevalent sexually transmitted infection worldwide after chlamydia. So let's talk about the mode of transmission of gonorrhea. It can be transmitted through contact with sexual fluid, including vaginal fluid and semen. Gonorrhea can also be spread from intercourse, like anal sex, oral sex, sharing of sex toys with infected persons. Gonorrhea also has a strong affinity for mucous membrane. Then let's talk about complicated and uncomplicated gonorrhea. Uncomplicated gonorrhea are much common, and they encompass any urogenital, anogenital, or pharyngeal infection caused by Neisseria gonorrhea. And uncomplicated gonorrhea does not result in bacteremia. Then let's talk about complicated gonorrhea. So these are infections that result in bacteremia and or the spread of bacteria to joints and tissues, and is considered a complicated infection. So when the infection is spread to the joints and tissues, is considered as complicated gonorrhea. Then let's talk about the clinical manifestation of gonorrhea. Clinical manifestations of gonorrhea. So over 50% of infected women are asymptomatic. That is, half of infected women does not exhibit any symptoms. The most frequent complaint is discharge and often accompanied with burning on urination. Then orophageal gonorrhea from oral sex may be present as sore throat. Symptoms of gonorrhea most often appear 2 to 5 days after infection in women, but it may take up to a month in men. So these are clinical manifestations of gonorrhea in women. Then these are graphical pictures. The first slide shows oral gonorrhea. You can see the sore throat, pulse feet spots. Then we have the vaginal gonorrhea. You can see the discharge. Then we have the penile gonorrhea. You can see redness and a thick yellow discharge on the penis. Then complication of gonorrhea. Gonorrhea, if left on treatment, can lead to ascending infection to the endometrium, fallopian tube, ovaries, and peritoneum. It can lead to PID. It can lead to ectopic pregnancy and infertility. And gonorrhea can also lead to premature labor when left untreated. Then let's talk about the treatment of gonorrhea. For both complicated and non-complicated gonorrhea, WHO recommend IV or IM ceftriaxone 500 milligram in a single dose for person weighing less than 150 kg. That is for patients weighing less than 150 kg, gonorrhea can be treated with a single dose of ceftriaxone. Then, if chlamydia infection has not been excluded, that is what this slide implies is that gonorrhea and chlamydia can coexist together. So, if chlamydia infection has not been excluded, treat for chlamydia with doxycycline. So, for mixed infection involving gonorrhea and chlamydia, we can treat chlamydia with doxycycline while treat gonorrhea infection with ceftriaxone 500 milligram single dose. Then the dose of doxycycline in chlamydia, as I've said earlier, is 100 milligram 12 hourly for a period of 7 days. Then for persons weighing above 150 kg, 1 gram of ceftriaxone can be administered to treat both complicated and uncomplicated gonorrhea. So let's run through the comparison between chlamydia and gonorrhea. That is, based on signs and symptoms, it has been observed that both look same, but they have some different attributes. Chlamydia and gonorrhea are sexually transmitted bacterial infection that share symptoms, including painful urination. That is, both infections share the same symptoms like painful urination and genital discharge. So, however, they are different in some aspects. So, for the case of chlamydia infections, when the person come down with chlamydia infection, it take effect. You see the signs and symptoms after 2 weeks. But in the case of gonorrhea, you see the signs and symptoms after 7 days of getting infected with gonorrhea. In chlamydia, there's bleeding with sex, and there is bleeding between period. The discharge of chlamydia is scanty, is watery, is transparent, and comes with smell, with this foul smell. But the one of gonorrhea is kind of abundant. That is like there's an abundant discharge. The color of the discharge is yellow and it is very thick, unlike the one of chlamydia that's watery and transparent. So the discharge of gonorrhea does not come with a foul smell. So these are the different signs of different comparison. We are talking about the comparison of chlamydia and gonorrhea. So these are the similarities and difference between the two. Then in chlamydia, there is minimal burning with urination. There's minimal urethral swelling and redness. There's minimal watery and transparent discharge in chlamydia. But for gonorrhea, there's a significant burning with urination. There's a significant urethral swelling and redness, significant thick and yellow urethral discharge. So these are comparison between chlamydia and gonorrhea. So these are how we can differentiate between the two. Although they come with almost the same symptoms, but they are different. They are different in the area of the color of their discharge and the flow of the discharge. While chlamydia is scanty discharge, gonorrhea is presented with abundant discharge and yellow with thick coloration, or yellow coloration with a thick discharge. So lastly for today, we are going to talk about cancroid. Cancroid is a highly contagious yet curable sexual transmitted disease caused by the bacteria called Haemophilus ducreyi. Cancroid causes ulcer, usually of the genitals. So one way to actually diagnose cancroid is that it comes with ulcers, usually at the genital regions. Cancroid is transmitted in two ways. Number one, it can be transmitted through transmission through skin to skin contact with open sores. So when individuals come with open sores of cancroid, the other partner might get infected. Cancroid can also be transmitted through non-sexual transmission when pus-like fluid from the ulcer is moved to other part of the body and to another person. A person is considered to be infectious when ulcers are present. So there has been no reported disease in infants born to women with active cancroid at the time of delivery. That is what we are saying, that this kind of infection is unique. That there has not been any reported cases of infant born with cancroid. So let's talk about the signs and symptoms. Painful and drainage opening sores and open sores in the genital areas. Painful and swollen nerves node in the groin. Begin 4 to 10 days after exposure. That is, an individual comes down with the symptoms after 4 to 10, between 4 to 10 days after exposure to the infection. Then these are the clinical manifestations. The first slide is showing the cancroid of the vulva. You can see the sores on the vulva. Then we have the cancroid of the lips. The second slide is showing the cancroid of the penis. Then how can we diagnose cancroid? You can diagnose it through microscopy, culture, and sensitivity of discharge from ulcer, that's MCS rather. Then you can also diagnose it through serological tests and also PCR. Then let's talk about the treatment of cancroid. So non-pharmacological approach include keep ulcerative lesions clean. So one of the first approach to actually practice is to keep the ulcerative lesion clean. Then incisions and drainage or excision of node may delay healing and is not recommended. That is, even if a patient comes down with this infection, we should not, that drainage and excision of node may delay healing, so it's not recommended. We should not burst it or drain the pus. Then a need for follow-up in sexual until there is a clear evidence of improvement or cure. Then let's talk about the pharmacological treatment. Pharmacological treatment includes ciprofloxacin 500 mg 12 hourly for 3 days. So for a patient that comes down with cancroid, you can treat the patient with ciprofloxacin 500 mg 12 hourly for 3 days. But you also know that ciprofloxacin is the family of fluoroquinolone, so it is contraindicated in pregnant women and children below 12. So for patients who cannot take ciprofloxacin, tablet erythromycin can be prescribed. Erythromycin 500 mg 6 hourly for 7 days can be used to actually treat cancroid, or azithromycin injection 1 gram. You can also use ceftriaxone 250 mg as a single dose to actually cure this infection. Then let's run through tips to lower risk of developing STI. Now this, we as professional and everybody, we have a role to play to reduce the burden of STI. We have to abstain from unprotected sex. We have to abstain from having multiple partners. Two, we have to be faithful to our partners. For married people among us, stick to your partner. Then for people who cannot do without having sex, it is like best for them to use a protection, which is condom. So if you can practice these three important tips, then we are going to reduce. I'm sure that we are going to reduce the burden of STI. So let me run through the slide again.
Dr. Leon, thank you very much for the amazing presentation. Thank you so much. I had a network issue. Thank you, Pam Olushola Yobami, for coming through for me. Thank you once again, Dr. Leon. You did justice to this topic. We appreciate you. So, okay, let me use this opportunity to thank our leaders that are here. Mama Ajotoluwa, so thank you for joining us, ma. Thank you for joining us. Pambaya in EPS HMB, Hospital Management Board, thank you for joining us in this case. Our energetic PSN chairman, Moreyemi Oshoba, thank you, ma, for joining us here. And so it is time for questions and answer. I know we have so many things to ask Dr. Oluyemi in this case. Please, you can raise up our hand through the icon there. So Babatunde, you can go. Babatunde Yusuf, you can go with your question. Or Famusola Obami, any of you. Please carry on.
Dr. Yemi, good evening, sir.
Good evening, sir.
Thanks so much for the wonderful presentation on the most common disease among our youth of today. But I have a question concerning the dosage. I noticed that the recommendation that we have on the dosage for the treatment of gonorrhea, it recommends that we use 50 milligram IM alone and also some other dosage formulation that we have there. But what I observe is that in our current practice within our community, we use more than the dose that is actually stated in those references. So I would just like to ask, what is your opinion? What is your recommendation? Are you saying that by we using overdose, are we actually using antibiotic overdose, or there is a need for us to stick to the guideline? Um, Most people don't actually work with what is stated in the guideline. And what do you recommend for the better treatment? Thank you.
Dr. Oluyemi, are you expecting more questions or you'll be
Yes, yes. Let me take all the questions at once.
Okay, you want to take all the questions, will you be able to contain all of them? Or will you take
Yes,
this
yes.
as
I'm writing
we
them
have
down.
so many people, so you are writing them down. Okay, okay. Famolukayo, you can go with your question. Famibon.
Thank you very much. I want to congratulate Dr. Oluyemi for the wonderful delivery. You made it very simple, very simple. Please, I just want to, I saw in your slide the part of resistance. Although you mentioned it, but I was thinking we're going to have maybe a resistant profile regarding some of the drugs recommended, like I saw azithromycin, I saw ceftriaxone, and the rest of them. I don't know, is there a documented resistance profile for this drug as of today? That is the level of resistance as documented global global resistance profile as regards the drug. Thank you.
Okay, all right, sir. Thank you, sir. Famoloyemi Oshoba, ma, your question, ma. I think you raised up your hand earlier.
Very nice.
Thank you very much. I raised up my hand, but I was
Yes, sir.
thinking allow others have the floor before I say something. Good evening, everyone.
Good evening, ma.
Yes, I want to congratulate Sipan. This is an opportunity for us to, on the go, I used the word on the go because I accidentally pressed something on my phone and voila, it was on the go. Google Meet on the go, like So you can actually get these learnings, these insights on the go. I think it's a privilege that we take for granted. And so that is why I celebrate these feats that we have been able to achieve this evening. I um yeah, my first observation is that um what I was going to talk about. That's why I said I would have preferred everybody to talk before I say something. Something about WHO recommendations. You see, in Nigeria, the problem we have is that we ourselves know that we play with standards. That's number one. And on the other side, when WHO gives a guideline, it is giving it generally, and we are talking about black, white, Caucasians, brown, orange, and all types of all races, all not putting into consideration the variations that may come in with the different races. So where I want to say something is, when WHO has given recommendation, what should happen is that the countries involved to now use that guideline to design what will work for their own citizens by doing their own study and coming to a decision on, this is what will work for our patients or majority of our patients. For instance, I was talking to a doctor some time ago, and he was like, and I said, no, you're giving Ampiclox 1 gram. 1 gram 4 times daily, and like it's supposed to be 500 grams. I said, Ampiclox the man put to check 500 milligram, you look 250. Already they have a stereotype in their mind, like we don't even know what they are bringing into the country. Because of that, we are going to. So all of these forces continue to put us in a place where it's difficult to have a treatment guideline, puts us in a situation where it is difficult to work with standard, puts us in a situation where we cannot even trust a system, because we cannot boastfully say that, okay, of the truth, these drugs that are coming in actually contain what they claim to contain. So all of these things we as pharmacists affects us in every way, because it's the pharmacists that usually signs off on importation. So what is your role there as a pharmacist? We have also added to drug resistance. If the recommendation is 500 milligram and we are giving 1 gram, that means automatically at any point in time when that person tries to use 500 milligram, it will never work, and so on. For instance, most of the STIs from the training, even before now, in fact, there was a time it was Ciprotab, just ciprofloxacin 500 milligram stats. But I've never seen anybody write that. It has to be 5 days, BD 5 days, BD 7 days, and all of that. So we keep making this war against drug resistance, bacterial resistance, impossible to win by our attitude and by our negligence, because we are supposed to be the ones that we're supposed to be the gatekeepers, the one that should ensure. But you will find out that in our pharmacies, in our community pharmacies, because we want to make sales, because I want that no, just give them. And you will even see pharmacies, give this, give that. You may know what the standard is, but because you want to make more money, and you know that your clients are desperate, you want to add everything so that they will come back, so that they will pay you plenty money and all of that. So in my own opinion, all of these things are food for thought for pharmacists. Let us go back and see. Let us go back and readdress these things. What can I do to make things better? It is like this as it is. Yes, I may not be able to change everything, but what little thing can I do to bring a transformation and bring a change and make things better for the population, the general citizens of Nigeria? Thank you.
Thank you very much, man. I think you've done justice to the first question raised by Farm Malik. Like, like I said, these are WHO recommendations. If you go through and every country has a standard treatment guidelines, but no thanks to chaotic drug distribution system in the country, no thanks to importation of exportation of substandard drugs to the country. We all agree that if you like when you say okay, so brand of paracetamol contain 500 milligram of active ingredient of acetaminophen. If you take it to the lab, you discover that by the time you are done with your experiment, you won't find that 500 milligram. That's why some people that are more knowledgeable about drug, we stick to the innovator's brand. Some people tell you if it is not this brand, I'm not taking it, because they know that there are so many substandard, there is so many fake drugs out there. So personally, I will not blame clinicians too. By the time you are working with generic, you give 1 gram, there's no effect. You'll be forced to actually increase the dose. Okay, let me increase the dose to 2 gram. Maybe it's going to elicit pharmacological effect. So what I said, like my slide, I actually make research, and these are WHO guidelines, recommended standard treatment. So I wouldn't blame clinicians when they use above the normal milligram of the recommended dose, especially when they are playing around with generics. So I think I've done justice to the first question. Then the question raised by Farm Olukayode about resistant. Of course, there are many resistant profile of antibiotics, but I can't cover everything in the scope of this presentation. Like I was reading earlier, we have more than 30 STIs, but we can't actually do justice to it in a day or within 1 hour. So I agree with you that there are resistant profile out there, but I did not capture it in the scope of this presentation. I hope I answered your question.
I think we still have some hands up. I think from Bumishola, you want to say something?
Very much.
Mama Joke, Mommy, you are actually raising your hand.
Yeah, okay, thank you. Can I speak?
Yes, ma'am, you can.
Okay. Thank you very much. I want to appreciate our speaker and for going through in a short time. And my concern is in 2 ways. As a grandmother, the rate of cross infection now will be very, very great, considering the way the youths now are looking at sex as if it's just a daily thing, it's a usual thing. From childhood now, it's so terrible. And the way we talk about it now, the way the social media carries all kinds of things. When you open your phone, sometimes you see women and men engaging themselves in public show on your phone. You feel like throwing the phone or deleting everything. How can we reduce this cross infection of this gonorrhea and sexual diseases, in fact, transmitted diseases? It's a big concern for me. Then too, I also say as a grandmother, we as individual parents and as young people, let us also advise our household, our loved ones, to change their opinion about free sex. Because at the end of the day, many people are not having children today. Not all of the people, because some people that are very, very bad in love, they still have their children. But some people have that challenge of having children, and it becomes a burden throughout their life. So we also need to do some work apart from drugs taking and all that. We also need some work to do among the youth on how to give some to give some respect to their body, so that in the future they will not now be crying all over the place. In future, they would have lost everything that can produce children and all those things. So I'm just pleading that when we have this type of something, we can also, and that's why I'm not advocating for, even we can have it among schools, this type of discussion. We can have it among schools and say talk of more of the social side, where we give them the technical side of scientific approach to what the damages these things can cause us. I want to say thank you and God bless everyone.
Okay, thank you very much, ma. Thank you. We appreciate you. So, Farmer Bayomi, I think you are raising up your hand. Farmer
Okay,
Bayomi.
thank you very much. Thank you very much. I must commend the presenter for that highly detailed presentation. He has proven himself as a clinically oriented pharmacist. Looking at the question of pharmacist Malik, yes, the chairman has spoken about that. But what I will say in that regard, when the guidelines state lower doses for certain infections, is what is actually there is, if you look at gonorrhea, for example, that responds to 1 gram of cetrazone starts, then together with another antibiotic, maybe azithromycin, or when you have azithromycin, 2 grams starts, taking care of it, it shows that it's a very sensitive bacteria. So the fact that 500 milligram of cetrazone will take care of gonorrhea, every infection doesn't have to follow 5 days course, 3 days course. It all depends on the sensitivity. It all depends on the MIC, the minimum inhibitory concentration of the. So it's based on the sensitivity. 500 milligram basically kills gonorrhea when given starting dose. But one thing that also gives me concern about the rate at which people come down with sexually transmitted infections, because I see it a lot in community practice. I see it a lot in community practice, and as Mommy said, the rate of sexual promiscuity is very high, even amongst the married. It's so high that I can beat my chest that 50% of married men are not faithful. In fact, 75%. 50% are regularly not faithful. Another 25% once in a while. That is the society where we have found ourselves. And the rate at which we see these STDs also gives me concern about how other diseases like hepatitis would have been spreading. So it's a serious concern. So thank you very much once again, our presenter. God bless you, and thank you everyone for joining. Thank you very much.
Okay, thank you for Babayomi for your input. So you don't give us the rate for the women, just give us for the men. So that you are 75%. We'll be looking for the rate for the women too. Maybe give us soon. So Family Shola,
Actually, women are doing better.
thank you very much. Family Shola, are you still there? I can see your hand. Okay, Family, you can go on.
Make a comment as regards what the secretary has just said, giving statistics as to whether men are faithful or not faithful. I want to say that number one, how many men has he attended to this year? Has he seen to 10,000 men this year? And has he kept statistics? We have to be careful how we infer. You know, if you see men in the month and 40 men of them whatever, that may just be the kind of person that comes to that your direction because of where the place you work, you know. So if there is no documented evidence to prove your statistic, please, it may not be correct. So I want to suggest that you may just say that in your practice you see a lot of men who are having this or that or that, but don't put statistics to it. Maybe that's correct. That may not be correct. So it's a head statement.
Okay.
Like 75% among us who are here who are married, they are also cheating, and you don't have any proof.
Okay, let me say this. My statistics is not. This is not. I'm not saying it. Like in an academic spirit. You get? I'm not saying it in an academic spirit, but as a community pharmacist who has attended, I've been a community pharmacist for over 3 years. So, and I've attended to a lot of people. I've seen several cases of STDs, and I know the way I interview people. One thing I can assure you is, anytime I suspect a sexually transmitted disease, and I ask, the first question I ask is, are you sexually active? Are you married? Those are the questions. Are you sexually active? 1. 2, are you married? 3, the third question is that if you are married, do you have side chicks? I've seen people telling me that, in this Nigeria, is there anybody who does not have a side chick? I'm telling you what I'm seeing. And anytime I ask that question, are you sexually active? I can tell you 19 out of 20 tell me yes. And those yeses, they are either out of wedlock. Those yeses are out of wedlock. So I know what I'm saying. If I'm giving you that figure, I know what I'm saying, sir. I know what I'm saying.
Number one, the person is sexually active. The person cannot say no. It is that answer most likely will be a yes. Number 2, my point is, you have no point. You have no database to refer to. You cannot say 75%. You can be irresponsible for that. You know, you can say your practice. 75% of people in my practice I have met have this. Fine. That is your practice. There are people here who have been into practice for 20 years, 10 years, have been practicing for about 10 years. There are people who have practiced for 20 years, 40 years here. And they will say, in my course of practice, you will not just put, I'm going to be careful. You know, as researchers, we can't just make blank statements when there is no reference point to. That's just my point. I'm not faulting you. It's what you have seen, you are talking about. Talking about your experience, which I'm also learning from. You know, I'm learning from your experience and what you have seen. But at the same time, you must put that caveat that it's your experience. And that from your experience, you can say 75% of people you have met in your experience, because you cannot give a blank statement and point to reference. You know what I mean? Thank you.
Thank you very much, sir.
Let's not drag the issue for too long. Even if I have done a normal research, it is still going to be my own experience. So that's the situation. That's all the situation in this part of the world.
Okay, all right. Thank you very much, sir. Thank you, the DPS Bishop Pharmacist Oladiye Kolawole. Thank you, sir. You have the floor to speak now, sir. I can see that you are giving your hand.
Good evening, dear colleagues. Let me appreciate Dr. Oluyemi even though I joined very late, but the one I met, we should not turn this medium to an argument of who is more faithful among the two sexes. I think, like Dr. Egbo said, it's a matter of your locality where you practice. Because Pharmacy Ogunleke, practices in an environment that is student field, and I also know that it takes two to tango. If a man claims to have come down with a sexually transmitted infection, of course he wouldn't have had it if he had not gone to the other sex. And you also look at this angle that which of the two sexes is feel more ashamed when they come down with it. Of course the man will be free and say, I have this. And in this environment they tell you, they give it all kind of name. Some will tell you they have sweetie, some will tell you they have toilet disease, all those kind of funny, just to like a cosmetic. But I think the issue we now have is how do we curtail this? Like Mizolu Amomi has actually said, from the point of view of his grandmother, the way the social media is now carrying all this thing is becoming so alarming. And I think we should go in that direction to ensure that the rate at which people come down with tests, the rate at which they come by this infection is drastically reduced. I also want to speak about the issue of WHO standards, standard treatment guidelines. You see, in Nigeria, we know the chaotic distribution of medicines, and we know that if someone tells you that no, I can't get relief from my headache until I take 4 tablets of paracetamol. Of course, you know that something is really wrong with the API in those drugs. So you now say, let me go for a gram of ceftriaxone, even adding a surfactant with it. You know that within the WHO standards, you are giving overdose. But what can we do? Some people might actually be pushing because they want to make sales, like one of the contributors. But to me, I think it's a problem that is attached to pharmacists, because they will tell you that maybe you are all those things. But I think our concern will now be how do we sanitize the system so that whatever you say 500 milligram paracetamol, you are sure that you are getting 500 milligram of the API, so that what you say is what the patient experiences. So I think it's a concern, and to me it's like a public health issue that should be handled. Thank you very much once again, Dr. Lee.
Thank you very much, sir, for that amazing input. Thank you very much, sir. We appreciate it. Mama Oluwasom, do you have any input, ma'am? I can see that you're still raising your hand. Do you have any input, ma'am? Mommy. Okay, Farmer Bayomi, you can take down do you have something I want to say? I can see that your hand is up.
Oh, sorry. I thought I had put down the hand. No, please.
Okay. Stay there. Okay, alright. So, from Dr. Olu, do you have any additional stuff to say regarding questions or suggestions from different hands? Anything?
No.
Okay, no. So, anyone with any suggestion, any input, the way forward to mitigate the way the sexually transmitted diseases are much in our environment? Is there any suggestion regarding that? I think too many people have spoken well regarding it. So if there is none, I think we will call this meeting a day. If we don't have, I think we'll call this meeting a day. Thank you, everyone. Dr. William, thank you for the fantastic presentation. Thank you for coming through. Thank you for beating everything down, analyzing it down carefully for us to understand very well. Thank you very much. And for the people that joined, I can see so many people that joined. Thank you for joining this space tonight. Thank you for learning together. It's been an amazing time. At least we've gained one or two things tonight. Thank you everyone for joining. We appreciate you all. We hope we see next month in another presentation, so we come around to gain more and learn more through the clinic, through the CPAN. Yeah. So I think we'll call it a day now. Thank you, everyone. Good night. Have a pleasant night's rest. Thank you.
Yeah,
Dr.
good night,
Oluwemi,
sir.
we appreciate you. Thank you so much. Thank you very much.